Very good evening, each one of you. Let me first take this opportunity to congratulate everybody who has joined us today for this informative lecture on World Physiotherapy Day. On the behalf of Society of Indian Physiotherapists, its members, its governing body, its founder member, wish each one of you who is present with us a very happy World Physiotherapy Day. As you know, we are doing this lecture for last 6 years. This is our sixth edition where we invite an eminent speaker across the globe. Most of them happen to be of Indian origin so far, at least 50% of them, and taken up a prominent positions at various level in the world, in one of the best institution. Continuing that tradition, we have with us today Dr. Shailesh Kantak, who will be delivering the sixth World Physiotherapy Day lecture. Thank you, Shailesh, for joining us and accepting our invitation to deliver this talk. We are also very happy to share that Dr. Yagna Shukla, the chairperson of National Commission of Allied Healthcare Profession, is also with us, and she's kindly agreed to inaugurate and deliver the welcome note. A warm welcome to you, ma'am. You have been always supportive of the idea of Society of Indian Therapists. We always remember that how it started way back in 2015.
Yes.
But thank you so much for all your support, encouragement, and kind of blessing what you have been giving us. I'm also joined with our president, Professor Savita Ravindra from Bangalore, who will be at the end delivering the concluding remarks and will thank the audience for joining us. So before we move forward, may I request our chief guest, Dr. Yagna Shukla, who has joined us to kindly deliver our welcome address so that we can start the lecture. Over to you, Yagna, ma'am, please.
Nitesh, I think
Thank you.
Shailesh has requested to unmute him.
Done.
No. Still it is
showing muted.
Mute.
Yeah.
Yes.
Yeah.
Very good evening and namaste. Respected Dr. Savita Ravindran Madam, Dr. Raju Parashar Sir, Dr. Nitish Bansal Sir, today's esteemed speaker, Dr. Shailesh Kantak Sir, esteemed member of Society of Indian Physiotherapists, and dear participants. It's indeed an honor to inaugurate 6th World Physiotherapy Day lecture as a part of World Physiotherapy Day celebration. Today's lecture on Beyond Strength and Motion, Harnessing Motor Control in Physical Therapy, Assessment and Intervention will be delivered by internationally acclaimed Indian physiotherapist Dr. Shailesh Kantak Sir. SIP, Society of Indian Physiotherapists, is a forum that has created platform for physiotherapists to connect, collaborate, and innovate. To remain updated and advanced is an essential process for physiotherapists to grow professionally. And SIP is helping in growing physiotherapists professionally by organizing such high standard lectures. I would like to congratulate Team SIP for organizing lectures of dedicated educator, mentor, and renowned professional for the benefits of physiotherapy of India. I would also like to thank again SIP for this honor and privilege given to me today. Movement is medicine. My profession is my identity, and my identity is my profession. Wish you all a very happy World Physiotherapy 2025. Thank you very much. And over to Dr. Nitish Bansal, sir. Thank you.
Thank you so very much, ma'am, for your presence and kind words. Your words of wisdom has always been of great help to each one of us, and your compliments to society at every forum has made us become more responsible and to try to achieve more. So we thank you for that, and also would like to thank you for all your efforts, what you're doing on behalf of entire physiotherapy community sitting in Delhi. Being in Delhi, I can understand how difficult it is to deal with not only with the weather, traffic, and road, but more importantly, the bureaucracy here. So thank you for all those what you're doing for our profession. I'm sure this will only increase the or improve the benchmark, and we will keep striving to make it better and better. So entire physiotherapy community is looking at you with a great hope that we will be in a different standards. Thanks to you for all your efforts once again and for your
Thank you.
time on inaugurating this lecture. Let me now take this time to introduce our speaker, who is none other than, probably doesn't need introduction to many of us, but he's here, join us, and accepted our invitation to deliver this World Physiotherapy Day lecture. It's the sixth edition of it. Let me try and introduce Dr. Shailesh Kantak, who is of Indian origin, did his BSc and MSc from the esteemed KEM Hospital in Mumbai. He is currently serving as a director of Pathokinesiology Laboratory at Rancho Research Institute and an adjunct professor at University of Southern California Division of Biokinesiology and Physical Therapy. He has also earned his PhD in biokinesiology from University of Southern California, followed by a postdoctoral training at the Rehabilitation Institute of Chicago and University of Maryland, Baltimore. Dr. Kantak's research examines neuroplasticity, motor control, and rehabilitation strategies to improve upper limb function after stroke and other neurological conditions. His NIH-funded work explores mechanisms of bimanual coordination, motor learning, and non-invasive brain stimulation. He is one of the sought-after speakers in almost all the international conference, and he has received the Stanley Cohen Award from prestigious American Physical Therapy Association, Neurology SNS Award of Excellence, and Arcadia University of Michelle L. Berger Faculty Scholars Prize. He is also a dedicated educator, mentor, and advanced advocate for community engagement. With these words, I invite Dr. Shailesh Kantak to come forward and deliver the sixth World Physiotherapy Day lecture. Over to you, Dr. Shailesh.
Thank you so much for that introduction. I'm extremely honored to be here. It is a dream come true to address this group, many of whom I see here and I have learned from. Savita ma'am, of course, but I also see Deepak Kachalia here. I took some continuing education courses from many of these people, and I'm really very honored to be here and speak to you all. Can you see my screen?
Yes.
Okay, wonderful. So I'm going to start by giving a really quick, Nitesh, thank you for that introduction. I had put a few slides focused on my journey, but I'll really breeze through them really fast. So I have had the opportunity to learn and work across these two continents. I was born in Mumbai and I studied in Mumbai. My professional education really started at Seth G.S Medical College, and some of my teachers really encouraged me to think beyond they gave me really good foundation for my work that I do right now. Give me one second. And immediately after my graduation, the first time I understood something or learned something about motor control, as the word motor control, was with her continuing education course with Asha Chitnis, and she got me excited about motor control. And then I went in for my PhD at University of Southern California and got to study under some really wonderful people who always allowed me to question the status quo and learn from that. I completed my postdoctoral training at Shirley Ryan Ability Lab. Then it was the Rehabilitation Institute of Chicago, and then University of Maryland. Across this whole journey, my work opportunities also supported my innovation. At many of the places I worked, including MS Ramaiah, Moss Rehabilitation Research Institute, Arcadia University, and now at the Pathokinesiology Lab at Rancho Los Amigos National Rehabilitation Center, I found excellent mentors and colleagues who really supported my innovation and sometimes even my crazy ideas. And so many of them did that selflessly. At all of these institutes and others, I found students who really loved me, asked me questions that led me to think beyond my limits and inspired me to learn more. I'm extremely and eternally thankful to all of these people. But my main inspiration really was my patients. I'm going to share with you a video of a young patient with stroke. And as you will see, this patient was, she came to the Pathokinesiology Laboratory. This was in 2024. She is walking with, this is a part of our clinical gait assessment with, it is an instrumented gait assessment with EMGs, and you can see her walk with a single point cane. She's walking really very slowly, more of a very short steps. Stride length is short, and she's walking with some amount of knee extension that is coming from plantar flexor tightness. She underwent tendo Achilles release and physical therapy, and this was her within 6 to 8 months. And what you can see here is she's not walking with a cane anymore. She's walking faster. Her stride length has improved. And so with all these factors, the question is, did her capacity for walking improve? And I would say yes. The kinematics are better. Walking speed increased beyond minimally clinical significant change. And she went from having a supportive device to not having a supportive device. However, while all these gait changes in the laboratory are quite impressive, a key question is if this improved walking capacity resulted in improved performance in real world life, in her daily life. And in many cases, the answer is not always necessary. So a patient with similar improvement actually told us that he is not able to go out with friends because he said, I quote, I have to stop or walk really slowly, leaning on my boyfriend if I have to look at my phone or if there is crowd. I would rather stay home. Now, what this signifies is that improvement in capacity for activity does not necessarily improve performance in daily life. Now, this is not a unitary phenomena with a single patient, but even a recent study by Lang and colleagues showed that out of 156 patients with stroke and Parkinson's disease who were receiving outpatient rehabilitation, 59% of patients who showed improvements in capacity did not improve their performance in activities of daily living. This is what we term as capacity performance disparity. And it is a factor that truly blunts the value of rehabilitation and needs to be addressed in rehabilitation if we are to have a real impact. So there could be a number of reasons for the capacity performance disparity that we see in rehabilitation. So let us begin with what we assess, because our assessments reflect what we are targeting in our treatments. And most of our assessments are based on capacity, like range of motion, strength, ability to move out of synergies like Fugl-Meyer, and activity metrics such as gait speed. Now, many of these measurements are obtained in the clinic. And fortunately or unfortunately, our clinics do not have the complexity of the real world. We often do not measure or quantify performance in real life, either via patient-reported outcome measures or using technology in clinical practice. With our assessment focused on basic metrics, our interventions are quite focused on range of motion strength, we do have activity-based interventions, but they're often guided with a focus on short-term gains and not long-term learning and transfer that really consider the complexities of the real world and often miss out on the psychological and emotional factors that are so crucial in therapy. Now, with all these targets like range of motion and strength, these are extremely critical. These are critical prerequisites. They are necessary, but they are not sufficient to result in true recovery of function in real life. And that is why we need to go beyond the strength, beyond the motion and strength, and include motor control. So with that, what is motor control? And when you ask people, it really depends on who you ask. Most scientists would define motor control as the way movements are controlled by the brain. While most clinicians I've come across use motor control problems to indicate problems with synergies or to indicate some deficits that cannot be explained by range of motion or strength. So how do we move forward? And fortunately for me, I have had roles in both of these, and I still work in this continuum, and I have an overlap in my work. And so I feel like in order to truly translate science into practice, we need a common framework to assess and treat motor control deficits that can be agreed upon by both scientists and clinicians. So what would that look like? So before I go into details of motor control, let me start with some terminologies. I want to begin with some operational definitions of three constructs: elements, processes, and mechanisms. So let's take an example. If you want to play music on a piano, you have access to keyboards, the keys and knobs on the keyboard that you can manipulate. And those are the elements that one can manipulate. Now, if you want to play a song, like for example, Lag Ja Gale, then you need a knowledge of what keys and knob settings go with what tunes and what tunes form a song. And this knowledge is the knowledge of processes. And then there is this underlying machinery, if you open the keyboard, that allows you to know what happens. And often expert pianists know that machinery. Now, if we take that analog and go into the context of motor control, the task, environment, and the individual, these three form the elements that we manipulate in therapy. But to optimally manipulate these, we need to understand what processes are affected in each of our patients and know how to assess these processes for examination and intervention. And finally, understanding the neuromuscular and plasticity mechanisms underlying these processes plays an important part in relearning and recovery. So let's focus on these motor control processes. And for simple purpose, let's imagine young Sachin practicing his batting. So when he's practicing batting, his sensory system is on fire. His vision providing information on the position of the fielders, movements of the bowler and the ball as it is released. Now, based on this visual information about the position of the fielders and his memory telling him the needed goal of runs that he needs to accomplish, he generates an intent of either playing the ball or going for the boundary. Now, let's assume that he has an intent to go for the boundary. Then he has to select one action from multiple actions. Like he could go in for a sweep shot or a straight drive or a cover drive. And based on whatever his past experiences, he chooses one of them. Let's go for a straight shot. Now, once he has chosen that action, he has to plan it about how hard or how fast he's going to hit the ball. And after all that planning is done, then he actually executes and we see magic. Now, based on the outcome of that particular trial, he gets feedback on success or failure, and that informs his subsequent trials or subsequent practice. That is how we learn. So here there are some key points. The first one is these processes engage sensory, motor, as well as cognitive and psychological processes. And these processes are refined through practice. So bringing this back to our patients, if we really want to improve the skill of our patients, we need to be able to assess and help our patients improve all these processes for activities of daily living. So how do we do that? So to simplify these processes for clinical translation, we propose that you divide them into 4 main processes: sensing and perception, the cognitive aspects of attention and executive function. Action planning and selection go into an anticipatory control because they are happening before execution. And then once you have the feedback helps you build a reactive control. Now, so far I've outlined these processes that constitute motor control. How can these be tested in a clinical context? And what framework could we use? So here is the framework that we are proposing. At the center of this framework is the task. And the 4 key processes work together in an interactive manner to accomplish this task. Now, although these are distinct processes, they interact with each other in a very task-specific manner. So how do we assess these? The key is understanding the principles of assessment. What are we really going for? The key goals of our assessment are to determine which of these processes are contributing to dysfunction and which of these can actually help task accomplishment. We also take into consideration the pathology of the patient to determine if the pathway to improved function will rely on recovery of the deficit or compensation. And finally, the key is to identify an intervention bandwidth, and I will tell you what that is in a bit. But the key considerations here are we have to make sure that this is task specific, and we also have to appreciate the variability and then manipulate the elements like task and environmental constraints to understand the recovery. So let's talk about task a little bit. Oftentimes, as therapists, we like to break down continuous actions such as walking into simpler blocks, such as stepping, weight bearing, stepping forward, and so on and so forth. What we know from motor control research, extensive motor control research, is that there is very limited transfer from part task to whole task in these elements, in these skills such as walking. And so while testing, you may not break these down into parts and test the activity as a whole. As physical therapists, we also know that variation in movement with the task is quite typical. In fact, it is a sign of healthy movement. So when you think about movements, it's not a single point variability performance, but it's a spectrum of variability that's normal. However, beyond this normal spectrum of variability, at one level, you might see reduced variability that is pathological, such as patients who shows co-contraction and fear, you see reduced variability. And on the other hand, you might see extremely high variability in someone who has cerebellar ataxia. Now, the last part where I want to talk to you about is the intervention bandwidth. Now, during intervention, we want to provide an optimal challenge, because if the challenge is too low or too high, then the learning benefit is really, really low. And there is an optimal level of challenge when the learning benefit is maximal, and that is our optimal challenge point. Now, when you manipulate tasks and environmental constraints, you're really trying to challenge or balance the challenge to allow the patient to complete the task, at the same time also make it challenging. And I like to think of this as finding what we term the intervention bandwidth, where at one end, the patient is able to accomplish the task with help or facilitation or assistance. And this end of the bandwidth is important because it really motivates the patient because they can do this. It really relies on reinforcement or reward-based learning mechanisms. On the other end, the task is challenging to perform. There are more errors, and these errors help learning through error-based learning mechanisms. And what I have found is, while working with patients, is we are allowing the challenge along this intervention bandwidth. So this is conceptual, all right? I'll get into how to do that as we go. So now let's take examples of each of these motor control processes. How do we assess them and how do we intervene? Starting with sensing and perceiving, we know that these are affected in neuromuscular injuries, oftentimes with neurological injuries such as stroke and spinal cord injury. You have loss of sensations. Perceptual deficits are quite common. As you can see here, this is an example of a patient with neglect where he's trying to stand up. And you can see he does not even look at the therapist. He does not cross midline at all. So these are some of the perceptual deficits that are very common. Oftentimes, even in those people who do not have neglect, many chronic stroke patients do not perceive their asymmetric walking as asymmetric. So there is a perceptual recalibration. And that's also seen in patients with ACL injuries. And it ultimately influences activities and performance. So how do we assess? We know as a part of our entry-level education, we teach you to do a simple proprioception, and that's important. But it's also important to assess how these sensory processes are used in the context of the task. So here is a patient with spinal cord injury, and as you see him walking, you will see that he is focused, his gaze is really focused on the ground. So he's looking down constantly, and he walks with some abnormalities. So what we did was, in order to see if he is relying on his vision, we used a simple glasses with blocked vision for the lower part of the visual field. And you can see how his walking slows down, but he also stumbles a little bit. So that tells us that he's relying on his visual senses. Sometimes that manipulating senses can also help performance. So here is a patient with Parkinson's disease, and you can see that she has a really fascinating gait. She's trying to really short steps, and we see this very so often. But when you give them visual cues, you can see those visual cues provide a much better sensory information to plan their movement, and their gait increases, their gait improves. So now how do we use these sensory information to modify or improve our interventions? Again, these are task-based interventions where we are manipulating sensory and perceptual inputs, and the goal is to determine that bandwidth. So some examples we've used are manipulating visual inputs using glasses that partially block vision, or walking on foam to blunt somatosensory and perceptual inputs. Some studies have used somatosensory stimulation as a priming prior to therapy. In some patients, use of rhythmic auditory feedback has been used to improve symmetry. Perceptual systems can be really manipulated using strategies like mirror therapy or prism therapy, as well as virtual reality. And when you use these modalities, it is really crucial to engage your patient in the tasks that they find meaningful. Recently, there have been advances in non-invasive brain stimulation that allow remediation, if you will, of problems like neglect using transcranial magnetic stimulation. Again, how can I as a clinician then change gait with manipulating visual input. So here is a patient who is he's a patient with Parkinson's disease, and you can see as he walks, he'll walk. He has really short steps, and one of the interventions that was done with him was to use visual cues to change his stride length. Again, now, as you can see, this was done on a treadmill, but the patient was given multiple cues on the treadmill to manipulate his step length. And he is doing so not by improving his step length, but really doing it in a variable manner. And what you see is, this is immediately after that intervention, his step length improves. So now he's taking longer steps going beyond the other foot. So that was about how these are glimpses. Each of these elements are a whole 1 hour lecture, but I'm going to just focus on them to give you a glimpse of each of those. Coming to cognitive deficits such as poor attention, executive function, reduced motivation, and self-efficacy are some key deficits that are observed in both neurologic as well as musculoskeletal injuries. While we know that these psychological factors affect recovery and return to function or activity, and in cases of sports injuries, there is more and more evidence that these factors also predict return to sport, we often don't test them or treat them. So there are multiple ways in which we could test some of these constructs during our assessments. One way attentional resources can be tested is using a dual task performance. This may mean testing walking while counting backwards by 7, or walking while carrying a cup of water, or walking while texting. I think walking while texting has a very high external validity. Executive function deficits often impair movements that require remembering instructions. For example, I have seen difficulty in teaching patients how to walk on crutches or wheelchair skills because they have short-term memory deficits, and that requires testing. Also, many patients might have fear of movement, or they might catastrophize that fear of balance, fear of falling. And those aspects we know restrict participation. And finally, motivation and self-efficacy, which essentially is a key determinant of real-world performance. Their own belief in their ability to perform oftentimes helps, is crucial for them to participate in the real world. How do we treat them? Again, we focus on practice, but with a cognitive behavioral difference. So it's important to engage the cognitive systems during task practice, and that provides a great way not only to challenge these patients, but also to make task practice more valid for the external world. And when you do that, it's also great to engage these patients in making their own decisions about what they're experiencing. Here, I'll show you a patient who's walking on a treadmill, and as she's reading
Little
from a
challenging. Is
journal.
that surprising to you?
And what you see is really,
Okay, try again.
it affects her walking. And she actually feels that someone is changing the treadmill speed, and no one's really trying to do that. And that's exactly how she recognizes her own.
Makes you think somebody's changing the speed of the treadmill, doesn't it? Absolutely.
Oftentimes, you might also want to think about how to set goals and use technology such as activity monitoring. This is a study by Thompson and colleagues that randomized patients with stroke into 3 groups. One group received fast treadmill-based training with treadmill-based as well as overground walking practice. The second group received step activity monitoring with a behavioral training to actually get those number of steps. And then the third group was a combination of both. And they looked at post-intervention. They looked at multiple outcomes, but the one key outcome was the number of steps that they take over a day. And what you can see here is they have at pre, they were very similar, but at post, it was a sample as well as the fast plus sample that showed significant improvements. Just training them with walking improvements. Now, these people showed improvements in walking speed, but they did not really take more steps per day. So in addition to, again, coming back to, in addition to the task acts, providing them with goal setting, activity monitoring, positive feedback, really changes their behavior. And that is what I think is very, very crucial. Coming to the third element, which is the anticipatory control. Now, anticipatory control, as just to remind you, involves action selection, planning, and sequencing those actions. And these processes are often affected in multiple pathologies, in such as stroke, Parkinson's disease, cerebral ataxia. Even patients with musculoskeletal pain syndromes also demonstrate impairments in anticipatory control. Now, selection deficits are often evident in what actions we choose. So from a political perspective, it is important to recognize that compensations that we often see.
So again, she reaches for the blue ring.
So here a patient is reaching and when we start to see that she did that in a sort of a flexed synergy. The therapist just comes in and
Shailesh, I'm so sorry to break you in between. I think there is some issue. The voice has started cracking in between. I really don't know. I am able to hear slightly better, but there are a lot of people who are writing on the comment box that it's breaking. I don't know if there is.
my voice is breaking or
Your voice is breaking. Maybe it's the internet issue, something, in case you want to check it. Or
let me see.
it was all fine till a few minutes ago.
Let me change. Give me one.
Sure. Do it. Maybe it's to do with the bandwidth.
How about now?
Slightly better, but now I can also hear the cracking sound. Are you able to hear me loud and clear?
Yes, I'm able to hear you loud and clear.
No, your voice is cracking. There's something with the internet suddenly which has happened. I hope you're using any external device for the speed or no, it's directly with the laptop. Okay. Anyways, let's.
How about now?
I'm sorry, it's the same. How about you want to try and rejoin in case if it helps? No, it's breaking. It's breaking a lot now.
Let me do that. Let me rejoin. I'm sorry about this.
No, sorry about that. Actually, that also tells us the speakers were very, very attentive and they were listening.
That's good.
Friends, just give us half a minute. Shailesh Kantak is trying to rejoin. Let's see if we can overcome the technical glitch. Technology is famous for it fails us when we need it the most. But hopefully when he comes back, he will come back with a better sound quality. We thank each one of you. There are about 60 of us who are here, and there are about 30 of our colleagues who are in YouTube with us, who is listening to this lecture live. We are grateful to Dr. Shailesh Kantak, who has taken up time. I know it's quite early in California right now. He took the pain to got up early and got in front of the computer to deliver this talk for us. Dr. Shailesh, can you please start afresh if it is okay?
Can you hear me now?
Yes, I can. It's very clear now.
Okay. Let me do one more thing. You really don't need to see me. I can also well, this was a good break. I can also do this. I can also shut my video down. So that way you can actually hear me speak. How about now? Can you hear me? Okay, good. All right. Okay, so I think that's important to understand that these, so coming to anticipatory controls, right? So here is a patient, as you can see, she was able to, she moves with a little synergy, and the therapist just comes in and tells her to relax and just keep her trunk straight. Just that one piece was able to correct her movement in the subsequent trial. What this suggests is that these abnormal movements are patients' choices of movements that they possibly learned early on when they were weak, but did not change despite of having recovered their strength. And that is not, again, just in stroke patients, but you also see that in patients with ACL injuries. So when they are asked to do, when they are provided with feedback, they can actually perform as well as as uninjured people. But when they are not provided that feedback, there is a significant asymmetry during a simple sit to stand. Planning deficits. So those are action selection deficits. Planning deficits are also seen often as slowing down of movements. When our patients can't plan their action parameters, they rely on feedback while moving, and that slows them down. So planning deficits are often evident as slower movements. So how do we work on these? The first thing would be altering task demands. Does it change patient's action selection? Now, as you can see here, here's a patient with stroke walking with significant asymmetry. He's a patient with right stroke, left side weakness, and he leans really on to his cane. Just taking away his cane allows him to really load that affected limb. As you can see here in his stance on the affected side, his weight is on one side, while when he takes the cane off, he is able to really load that side. So just changing the environment changes it. Speed. Manipulating speed is another important way to test anticipatory control and see if manual cues can help patients change their action selection. There are multiple interventions that can be used to improve anticipatory control. Task practice with high intensity and optimal challenge is crucial. Recently, we completed a trial where we showed that fast movements that rely on anticipatory processes, when they are practiced in a fast manner compared to slow, accurate movements, they actually improve the patient's anticipatory control. So what I'm showing you here is a number of peaks in their velocity profile when they are doing a simple reach. These are patients, and compared to before and after, when, compared to pre-test, at post-test, the speed group improved their reduce the number of peaks, which is essentially a measure of anticipatory control, while the accuracy group did not. And so another example of using interventions to improve anticipatory control is variable practice, changing the environmental and task demands. The current clinical practice guidelines by the American Physical Therapy Association suggests that the use of high intensity and variable stepping to improve walking outcomes. Last but not the least is the reactive control. Reactive control is really important when we are faced with unexpected perturbations during walking or balance activities. And this kind of control, to a large extent, relies on sensory feedback signal that signals error, and this triggers error-based mechanisms. Now, when it comes to learning, this error-based learning is also called as sensory motor adaptation, and it relies on what we call as the sensory prediction error. So for example, when someone is, when someone is playing dart, when they throw their dart, that motor command, while leads to an action and effector activation of muscle activation, it also results in an efference copy that allows the system through cerebellar control to predict what this is going to do. Am I going to go at the target? Am I going to hit the target or no? So that's even before the movement is emerging. And that discrepancy between actually what the nervous system predicts and what the nervous system observes is called as a sensory prediction error. And when that error is affected, that error forms a very important learning signal. And that is why we know that that errors are extremely essential for learning and recovery. But when you test for errors, the first important piece is safety is key. You want to make sure that your patients are safe. When you give them perturbations during task performance, and you can do that with repeated perturbations or unexpected perturbations. Sometimes these unexpected perturbations are often predictive of patients who will fall. For example, people who have a sidestepping strategy with a lateral perturbation rather than a crossing strategy are more prone to falls. Now, how do we challenge the reactive control? By increasing error. So your goal is to really make error a key piece of learning. So you're moving right on this intervention bandwidth. You allow task completion, but you also increase that error. And one of the key things with patients here is you want to balance rewards so that they maintain motivation. And that is why I like this idea of intervention bandwidth. You can change your error to motivate them on the left-hand side while challenging them on the right-hand side. This is another example of a patient who had difficulties doing sit to stand. So you see, he kind of stops in between. And what we did was the intervention was to increase the error. So we made this task really difficult. So as you can see here, he struggles. He really struggles a lot over multiple trials. You can say his movement is not perfect, but that short intervention gets him a better performance at the end. This is another patient who has antropropulsive behavior during walking. He walks with a little forward, a little backward bend while walking. And what the intervention was it was on treadmill, but we gave him a little extension, resistance into extension. So that error of was significantly increased. And what you see with this patient over, a single session was, was that they do show improved walking without that. So that's the change with one single session. And it is not, the key is to enhance error. And that is something which as therapists, we try not to do. We try to go for normal movement. And what I'm suggesting here is it might be good to increase that error. So in summary, these motor control deficits are complex, but they're fun to manipulate and treat. Task deficits, task is crucial, and deficits that are seen in one task may or may not be extrapolated to others. Sensory predictions or sensory perception system, you can manipulate the availability of sensations in the context of the task. In the cognitive domain, you can manipulate attention, executive function during task practice. Anticipatory control, you can change task environmental demands, provide cues, increase speed. While for reactive control, you can provide perturbations and allow them to adapt. So in summary, I suggest that there is need to move beyond the clinic to improve performance and engagement in real life and community. To be able to do that, we need to understand motor control and allow consideration of individual patient, task, and environmental factors that our patients function in. And while we do that, understanding the cognitive sensory motor processes that are involved in task-based motor control can be assessed and manipulated. And finally, assessments need to go beyond the clinic into daily life, beyond the clinic and laboratory. So getting measures from daily life activities. With that, I will stop here. Thank you very much. I wish you all a very happy World Physiotherapy Day. And again, thank you very much for inviting me to give this talk. I'm open to questions and comments.
Thank you. Thank you so much, Shailesh, for sharing such a wonderful lecture today. As per plan, the floor is open for question and answer, if any. Before we invite Professor Savita to deliver the concluding remark, may I request Professor Shailesh if you can minimize the presentation and be present on the screen. We take the first question, which it comes from Shivam Sharma. What should be the error rate within we train elder people, while we train the elder people?
Can you allow me to open my camera?
I am sorry, I think.
It's okay if you can't. That's okay. So the error rate is really going to be different for different people. So if your patient is in a very early phase where the patient has fear or has issues with confidence, your error rate is really going to be lower. So when you're working on the left-hand side of that intervention bandwidth, where you provide feedback to improve his confidence. But as they are improving their confidence, you can slowly start increasing the error rate. Now, this is the difference between research and practice. In research, I can really systematically reduce that error rate. But in practice, that becomes really difficult because when you practice, that is not going to be a specific value for every patient. You will have to test and see. So you can have two people with very similar balance, but one has high confidence and one has low. My error rate for them is going to be very different.
There is another, I'm not sure if it is a comment. It was a great session. You have explained MRP in a very simplified way. So we have a colleague, Shehari Thapa. In addition to the above, what is the carry-on effect of this at home? In a clinic setting with the we can see and differentiate difference, but with no sustainable practice, they will adopt back to poor posture. How can this be adopted?
So the way I think about this is during therapy, you are not just making them walk. You are giving them experiences that go beyond what they have experienced. And once you show them that is what they can do, and you give them accountability that how can you take this at home? How can you change this? For example, I work with patients with poor movement of the arm. I work with them and say, okay, we've done all of this practice in the clinic, but what can you do at home? Let us spend around 10 to 15 minutes at the end of the session to identify activities that you're going to be doing at home. How are you going to engage that weaker arm into your those activities? And so that gives them something to go off. So using things like Fitbit or using things like simple accelerometers can also provide them, and giving them feedback about where they started and now how much they are using their arm, that also improves their ability to translate this at home.
Great. So we have the next question from Kshitija. She wants to ask, how do you tackle with social issues related to these deficiencies, specifically gait?
Oh, that is such a great question, Kshitija. Social issues are important because, for example, I might have a patient who, and this happened in Philadelphia when I was there. We had a patient who was really improved their walking, and we were like, why can't you go and walk outside? And he was like, there is nothing to walk outside. When if I go outside, it is really at a level where I don't have any space to walk outside. So that's the environmental constraint. That's the social aspect of where he was living that that the patient was not able to do that. So then coming up with, then going beyond just what we are going to, focus on physical, you might have to address and find out resources for the patient. Like what we did for him was we found if he had any YMCA nearby that he could go and walk there. So that is the piece that that you will have to incorporate if you're really wanting to improve things outside. That's a great question.
We have another stimulating question for our founder president, Dr. Raju Purashar, who wants to ask you, discrepancy from lab clinic to ADLs, is it because of training in closed environment to open environments?
Absolutely. Closed environments are really, you nailed it. It is, when we practice in closed environments, things become so predictable. While when we go outside, nothing is predictable. There will be different people walking in different directions. There are cars that are coming in different directions. So going from, and that is where the variable practice, that is where you change the environment all the time, that at least gives you some semblance of changing things so that they get an experience of a variety of motor control strategies that they can actually practice during therapy. Now, if you can take the patients out into their environment that is as dynamic and train them there, I think there is nothing like that.
He has also asked about, could you comment on motor control deficit secondary to peripheral disorders such as OA and the consequent motor control adaptation?
Sure. There is a lot of work showing that many of these chronic deficits, or chronic conditions like osteoarthritis or low back pain, they change how we move. And that aspect of how we move, how we change how we move, is all related to motor control. So, for example, we see patients who have ACL injuries. And after ACL injuries, they go through rehab, improve their strength, improve their range of motion, but still are asymmetric while they are walking. And that asymmetry is not something that they have because of the injury per se, but it is an altered action selection. That's how I think about it. That's an altered action selection. Now they've learned that technique of loading the good limb more, and despite having the capacity to load the affected limb, the patient is still relying on the previously learned strategy. And I think that's important. That to me is a motor control issue. So if we want to train that, we have to really go beyond, like I would go really error-based learning, where we force them to use that affected limb in a variety of situations, a variety of environmental conditions, variety of task conditions, and with an understanding that that might be a better way to help them change.
Lovely. We have our next question from Anu Arora, who wants to ask you how to assess motor control in a busy clinical setting beyond standard strength, range of motion testing. If you could suggest some simple but efficient tools. She's really asking trade of the tricks. Tricks of the
Trade of the
tricks.
tricks are this.
Trade
Trade of the tricks are this.
Tricks of the tricks.
So this is something which I learned when I was a physical therapy student at GS. You have to really hone in on your observation skills. So when a patient is walking, for example, where is the patient looking? We are so focused on, is he going into knee hyperextension? Is he getting that knee flexion? Absolutely. You do that, but you also look at where is the patient looking? What if I change the environment? What if I put an obstacle in between? So you're testing all of these factors, you're observing. So that's the first piece. And then based on your observation, change, or for example, if the patient is really focused on the ground, I might change the variable, I might change his vision. Or if I feel that he has a problem with proprioception, I might change the surface that he's walking on. If I feel like he's really walking slow, I can ask him, can you walk faster? So you are really packing these. You're not doing a separate assessment here, but you're really packing these, you're testing these elements as a part of your movement analysis. And I don't think it takes a long time unless you are, for example, going to do a standardized assessment for balance, which I absolutely advocate for. But I also understand that in a really busy clinical setting, that might not be possible every time the patient comes in. But I will still strongly encourage you to do those standardized assessments, at least at the beginning and one at the end, because that helps you show the patient also that they can improve. Another way to really, this was a great way to kind of, this was a beautiful study. What they did was they just made the patients walk, but they told the patients every session how much they have improved. That's a very simple thing to do, to have them do a quick 10-meter walk and tell them, you started at this and now you're at this. That itself increases their confidence. That itself increases their motivation to participate better. So I think you can still assess motor control in a busy clinical setting.
Great. That sounds really great. What a wonderful Monday evening and the way to celebrate World Physiotherapy Day. Thank you so much for the question. Let's move on to the last question. Since we already crossed 7, our colleague Meena Makhija has asked, any experience you would like to share from your experience of patients with shoulder problems?
That's pretty broad, but shoulder problems in
and we have Vaibhav also, adding to it, what about hand functions with your method? So I think this could be the last question before we end.
Okay, so I'm gonna assume that you're talking about shoulder problems in patients with stroke, and hand function with stroke. I think frozen shoulder. Frozen shoulder and motor control also have a few things together. So for example, you work with frozen shoulder patients. They start working with, elevated shoulder. As your pain reduces, your range improves. Sometimes patients with frozen shoulder continue to use that excessive shoulder elevation, despite having the ability to improve, despite improving the range of motion. So I think that is again a motor control problem, and allowing the patient to understand that they are moving in an abnormal way and how can they change their strategy would be another good way to train. About recovery of hand functions, that's Vaibhav, so nice to hear from you. But recovery of hand function with my method, I'm not going to say that range of motion and strength are not important when it comes to hand function. Those are absolutely important, but you have to go beyond that. So you might want to start using things such as FES, somatosensory stimulation. Mirror therapy helps. Currently in the lab, we are using virtual reality to test the effects of that on hand function, virtual reality on arm and hand function after stroke. So those are some of the ways that you might be able to use some of this in patients with stroke. But again, with stroke recovery in hand, there is sort of there are multiple types of impairments. Some of them will show you significant recovery, while some of these patients will not. And then that case, you have to go with a compensatory approach.
Thank you, Shailesh. Looking at the curiosity, I can very well understand how interested your lecture has generated among our audience today. But unfortunately, we have already crossed the timing. So thank you so much. I am really sorry for those whose question I'm not able to take up right now. We will have to move on to our next step. Maybe we can share, if Shailesh allows, his email ID, and any one of you interested can be in touch only in case if he allows that. So thank you so much for all your questions, and Shailesh for patiently answering them in detail. May I now move on to our President, Professor Savita Ravindran, to kindly take over and have her concluding remarks before we end this lecture today. Professor Savita Ravindran, please. Try that, ma'am, now.
Yeah, thank you. Shailesh, two things. You're an amazing teacher. You've been that and you continue. Because
Thank you.
I'm so far away from adult neuro, but today I understood a lot. So thank you to you.
Thank you so much.
Yeah. Always a pleasure to listen to you. Always a pleasure to see the passion, and just keep going there. And you have to commit to us that you will come to our SIP conference the next time, and you will take a kind of workshop so that people can attend and learn in person.
Absolutely. I definitely will.
Thank you.
Thank you.
Thank you for your time, and really very nice presentation. Appreciate it completely. Thank you.
Thank you all for having me over, and thank you for spending this whole evening with me today. I'm really honored again and very humbled that to be able to do this. This is a very meaningful thing for me.
Thank you.
Thank you. Great. Thank you so much
for
sharing your time. I know it's early morning and you might have to rush, and celebration at your end. We thank each one of you who have joined us today to celebrate World Physiotherapy Day on this 8th September. This is the 6th lecture of our series, and we hope to continue. Please feel free to write to us. And before we end this talk, I would also like to invite each one of
Shailesh, there is somebody by the name of Swati who says, "Hi Shailesh, thanks. This is Swati, your junior from Australia."
Oh, Swati Lavekar, she was my junior at KEM.
Yep. So you see, people across
yes.
continents are listening to you.
Awesome. And here is my email. So if you have questions, please email me.
Thanks for sharing. And I would also like to share that we are organizing our 10th annual conference in Hyderabad. The dates are 23rd, 24th, and 25th of January. We invite each one of you who would be interested to kindly register and attend. Right now, the reduced advance rates are still open until April 10th September, so take advantage. And we look forward to seeing you in Hyderabad. So thank you once again. Special thanks to Shailesh. Professor Savita, our president, and all the delegates who spared their evening for us and attend this wonderful lecture. Thank you so very much once again. And I wish you all a very happy World Physiotherapy Day on behalf of entire Society of Indian Physiotherapists. Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.